Well, good day to you all and happy Easter. We're in our Easter festivities. This is the Bald Headteacher Podcast, and I'm here today with my great friend, Dr. Tom Gillham. It's going to be a great episode. Welcome to the Bald Headteacher Podcast. Easter greetings to you all. As you'll find out shortly, I've been both on pilgrimage and retreat this week, and I feel all the better for it, though my feet don't, but they're getting better. Anyway, since the last podcast, there's been plenty of news, hasn't there? Particularly the war in the Middle East, and however this war pans out, the impact on all of us is going to reach into our schools, and yet more challenges are going to present themselves to our school leaders, to our teachers. There are tough times ahead, I would think. And one of the recurring themes of this podcast is, the lengths we are going to make things as difficult as possible for the next generation, for today's children, for the future. The more war, the more aggression, the more vitriol, the more division, the less we're talking about how we can care for the future of our common home, about how we can live in this amazing world together, how we can be joint stewards of the future. I really think sometimes, what example are we setting to our children? And it was in that context that since the last podcast, I was very disappointed and quite irritated, I think, by Sir Martin Oliver's comments. He's the HMI, Chief HMI, Ofsted. He made these comments about the low expectations we have for our children. Well, I'd say to him, can you not read the room? I mean, just try and run a school where almost every river of support has been drained away, leading schools to become this fourth emergency service. We're picking up the pieces. We're doing our very best in the circumstances. Now, of course, there will be exceptions. There will be exceptions where there aren't enough high expectations, but you don't define strategy on the basis of a few exceptions. And I really do think the Labour government have missed a real trick here, one of many actually, and they could have abolished Ofsted when they came in, when they had the chance. I think it's a big mistake, and I just can't see the purpose of it now. It's a completely different age to the 1990s. We are living in a different age, and we need a different strategy. But the challenges get bigger and bigger, and this week I want to explore one particular challenge, one that is becoming increasingly difficult for school leaders, for teachers, for parents, for health professionals. So here's the question. Here is the challenge to consider. Are we witnessing a genuine rise in mental health need among children and school staff? Or are we increasingly viewing the pressures of modern life through a medical lens? Across our schools, more children are being described through diagnostic labels: anxiety, ADHD, autism, emotionally based school avoidance. At the same time, increasing numbers of staff are absent, and the numbers are rising significantly. Education is more and more coupled now with health. It used to be NITS. When I first became a head teacher, I remember going to the first school where I was a head teacher for my first visit, and I walked down the path. There was nothing. There was absolutely nothing to welcome you to the school. There was no sign saying, welcome to such and such a primary school. There was no kind of, these are the main teachers, the head teacher, the number, all that kind of stuff. There was only one sign on the door: meningitis kills. Meningitis kills. But in those days, that's what it was. Meningitis, public health messages, and the school nurse for NITS. But it's so different now. We are coupled together, education and health. And recent well-being research suggests that around 3/4 of education staff report significant stress. Almost the same proportion say that work has led to symptoms of poor mental health. In many schools, mental health-related sickness absence has risen sharply. And I tend to agree with this idea of a moral injury that we've got, and this I think is the case in the NHS as well, that people are going home so deflated, so demoralized, because they are desperately trying to do what they came into the job to do, which was to make outcomes the very best for their children, for the patients and whatever. But they're going home because they haven't got the necessary time, resources, and so on. That there's this feeling of sort of moral injury as they go home in the evening, and that's, I think, what is giving rise to this. But there are other opinions. Are children genuinely less well? Are our schools and families increasingly seeking medical explanations for what might actually just be social, developmental, environmental pressures? And for staff, is it a symptom of a system that is asking too much? Or is it a real clinical need that we're seeing? What is the line between distress and disorder, between diagnosis and support, between resilience and burnout? We're not denying need, nor are we dismissing the very real struggles that children and adults face. This is about asking whether schools are increasingly being asked to carry the weight of wider societal pressures, and whether in doing so, we risk medicalizing what might actually be systemic. And if that is the case, how can education and health work better together to meet this rising challenge? So to help me navigate those difficult questions, I'm joined by Dr. Tom Gillham, who is a GP and a medical director in Hertfordshire, and he also happens to be my brother-in-law. Tom, welcome to the Bald Headteacher Podcast.
Jeremy, thank you. It's a pleasure to be with you.
Before we get onto the medical, the medical and education coupling, we've had a bit of a walk this week, haven't we?
We have had a fantastic walk, and it was your feet, but it's my knees that are struggling this morning. Fantastic 2-day walk, which you planned yourself, involving all the family, all the kids, and walked across Lancashire, didn't we, from Parbold.
We did.
From your father's graveside, which was very poignant. A 2-day trek through Preston to Stonyhouse College, and it's been a fantastic time with family, reflecting, some brilliant conversations, and some real well-being, actually. Well,
it is, ironically, walking, I think, is a fantastic thing for well-being.
Yeah.
Any highlights from the walk?
So many highlights. I mean, losing my shoes was was a low point, and I think you were there to support me, as both of my shoes got stuck in the mud at one point.
There to support you.
And you lent me your socks, which is very kind. But it was a brilliant thing to do. So thanks for organising it.
Yeah. Good. Well, and we're currently on retreat, and that's been a great time just to reflect and ponder and think, and we'll hopefully go back. I'd encourage it for anybody, actually, any kind of retreat opportunity, secular or religious.
Yeah, great.
Anyway, let's just start with the clinical side of it, because I think what a lot of listeners will want to know, Tom, is because a lot of listeners are people working in education. They often see the GP appear in letters, and they see them appear in parents talking about going to see the GP and so on, but we don't actually see the person behind that.
Yep.
And it'd be really interesting for you to give us a bit of a clinical reflection on when does normal childhood distress become something clinical?
Yeah, that's a really interesting question. So distress to kind of disorder or something that's normal societal behavioural into a kind of medical diagnosis, you're looking at 3 main things really: intensity of the disorder, and then the duration of it, and the impairment. So how is the child affected by it? How long has it lasted? Typically something which goes on for 6 months, which is affecting things like school, relationships at home, that would become a disorder. That's when you need to intervene. So it's a difficult area to define neatly for you, but essentially it's how long has it been going on for, what's the impact, and what's the impairment on the child or the adult.
And I think what's really interesting is when we've had a chat about this, you're not often the person that's actually dealing with that, are you?
Yeah. Absolutely right. So all our stuff now is triaged. So to access your GP, you will have found this yourselves probably. You use an online consultation tool where you fill in a form essentially, which comes to the practice. It then gets triaged by a clinical triage team that's not always the GP. And then that gets assigned to the most appropriate person. It might be me, it might be minor illness, it might be a well-being nurse. So sometimes some of that stuff won't come to the GP, it might go to a allied health professional.
So in all truthfulness, do you actually really know these families? Have you worked with them in other areas of health development previously, or are you just reading very quick notes and then you have to make a very snap decision about?
Yeah, so we are triaging literally off a few lines that the patient has submitted to us and trying to make a call in terms of the best and most appropriate, efficient use of our system. And you're right, 20 years ago, colleagues of mine that I first worked with who retired since, they knew the families, they knew the adults, they knew the cradle to grave care. That's really hard to deliver nowadays with other pressures. And we talked before, didn't we? We have lots of pressure in terms of patients with dementia and frailty. And that means we struggle to really get to know families the way we did 20 years ago. It's a shame. It's a real shame.
Yeah, I was going to say, do you find that doctors and nurses regret that?
Yeah. I think so, because it's really satisfying when you recognise a family or see a face that you haven't seen for a while, and you pick up where you left off. But that doesn't happen very often anymore. And of course, getting to see the same GP is very hard these days. So that continuity of care is practically impossible to deliver given today's stresses on the health system.
Yeah.
Now,
there's no doubting, we know it because the stats are there, this huge rise in EACPs, huge rise in assessments and diagnoses and so on of children. That's the stats say. I think it was in my last podcast with John Patterson. From your side, how can you get involved to almost stem that if it's the right thing to do, or otherwise? I think it's really interesting how we see GPs, the cynical people in education would say, oh, all they do is just sign it, whatever. And then because they haven't got time, whatever. Is that true, or?
Is it true, Jeremy? What's the right thing to say? Well, listen, we're under a great deal of pressure. Of course we are. Do we always deliver the sort of care and the quality and the assessment we'd like to? No, we don't, to be perfectly honest. And I think a lot of that is affecting the way we deliver care, especially for mental health for children. And we are too far removed from it, for all sorts of reasons. So yeah, I think that's a valid point.
Okay. Yeah. I listen, we appreciate it. Okay. We appreciate it's everybody. I think at the heart of all this, there's just not enough time. Is there? What about resilience? Do you think we're at risk of confusing low resilience with illness?
Yeah. I think these days, there's been a bit of a destigmatization of labels. So ADHD, ASD, anxiety. 10, 15 years ago, people didn't like to have that diagnosis. Nowadays, it becomes a bit of I've got that diagnosis. It unlocks, help in certain, unlocks support, certainly. And so there is a sense that perhaps people are sort of seeking them out a little bit more than they did 10, 15 years ago, and they're not stigmatized the way they used to be. So that's certainly happening. Yeah.
You've noticed that?
Yeah.
In the surgery?
Yeah, and especially if you get a parent that's got 3 kids who are older than the child that's presenting with, who've all got a diagnosis, and they come in, sometimes the kid might be 1 or 2 years of age before really even showing any symptoms. But of course, because there are 3 siblings with a condition, the parent very much defaults to, they need a diagnosis too. And that is in part driven by the fact that getting a diagnosis has unlocked support for those other 3 children. So that's definitely happening.
I remember seeing that as a head teacher. Was a group of parents walking in front of me as they were leaving, and reception. So this is reception. So the child was 4 years old, and this mum said to the other mum, I've just been to the GP. He's got it as well. Got it as well, 4 years old. And it was obviously because the elder sibling was diagnosed with autism, and he's got it as well. It was like he caught it or something.
Yep.
So you think that's definitely something that's changed inside the destigmatization? Yeah, I think you're probably right.
Destigmatization plus an expectation from the parent, or a bit of misunderstanding that because those 3 have got it, this one must have it too. GPs, frankly, haven't got the diagnostic skills to be able to say no to that, or the confidence. They're under pressure from the parents to get that diagnosis sorted. We're not great at managing some of that stuff. So we're quite happy to move that or refer on to a team that can make that diagnosis. And again, it's because, as you said before, a lot of it's time. There are so many factors in some of these diagnoses. There's behavioral things, there's stuff that's happening at home, there's parental mental illness. multifactorial, and actually it's so complex. We want to push it to someone that can manage it.
So let's talk about staff. Okay.
Yep.
I mean, I was looking at a Schools Week report, various teachers offering their own testimonies. This head teacher said, I had 3 periods now where I had to take time off work because I've just been so run down, so stressed, so exhausted. It got to a point where I think running the school to the standard that I want to run it to is almost an impossible job. And a lot of that is pressure that we put on ourselves as leaders, but a lot of that, it feels like the system is working against you. There was dozens and dozens of these testimonies. And as I said before, the stats are just showing this huge rise in absence now, staff absence.
Yep.
And again, a lot of school leaders, governors, trust leaders, and so on are wanting those stats to change because it's a metric of success if you've got high staff absence and so on. Again, I think we see GP and we think sick note. Well, fit note, isn't it? We think they're just signing. Okay. So tell us from the other side, okay? Because I'm sure that is not the case.
Yeah. Listen, it's so hard to comment for every single GP, isn't it? There's 35,000 of us and there's 6,000 practices across the country. But I know the stress that colleagues are under and the pressure of time. And I know too that a fit note, as you correctly say, well done, a fit note is a relatively straightforward thing to issue, right? It takes 2 minutes and you can take a long time over it because you want to make a proper assessment, or you can just get it off your plate because you've got so many other things going on. So I can't say hand on heart that there is a rigorous assessment for every single note that we're issuing. GP colleagues that are watching this, please don't shoot me. So is that a good state of affairs? Am I proud of that? No, because that doesn't feel right at all, even saying it. But I'm just being honest with you. And as I said to you before we started filming, sometimes Med3s are done by, or fit notes are done by non-GP professionals. So we will delegate work to a suitable or an appropriate alternative clinician, sometimes a mental health nurse, a paramedic. They'll make the assessment. Again, can I say that the rigor is there? Do they have the same standards, to say the same benchmarks for fit notes that we do? Probably not. And I think the other thing we said was sometimes a member of staff might be struggling in the early stages of anxiety and come to us and all they need is some support. But often colleagues are too quick to, including me, write the fit note. They're off work for 2 weeks, sometimes a month, because we think they should get a good amount of time to manage their stress. But as soon as you do that, you compound the issue because it's much harder to get back. And I don't know if I'm going to, next time they ask for a note in 4 weeks' time, it might be the pharmacist or the paramedic or the mental health nurse that assesses, not me. So there isn't continuity again. So suddenly, 2-3 months down the line, your staff member that could have done with a bit of support early is now off, has been off for 3 months.
That's the thing, isn't it? Because again, I was doing some research, and was a fantastic study by Loughborough University, and they had found researchers from Loughborough University in the Office for National Statistics. They carried out a study in England, and there is a definite, this was with children, but I think it's the same with staff as well, because we're talking people here. There's a definite correlation between the longer you are absent from school or absent from work and an increase in the mental health problems that you might be suffering. So we have to get children back into school, and we have to get staff back into work, because their mental health potentially would get better as a result. But we also have to deal with the fact that they are genuinely stressed. There is genuine anxiety there because of what we're calling systemic pressures, or are we? So we try and unpick that a little bit, I suppose. I suppose, first of all, do you agree with me that maybe this is a systemic issue that is causing this stress in the first place? Without betraying patient confidentiality, do you feel that is partly the reason why people are coming to you with such stress?
Do you mean pressure in terms of pressure from the environment they're working in?
Yeah, the pressures from the system, the expectation, the moral injury I'm talking about, the expectations of the system.
Yeah, if I have a teacher that comes in and sits down and I'm like, I actually get to see them, not just manage it on the phone. I see a teacher, and I think the most striking presentations of anxiety and stress is generally from the teaching profession, actually. And I often say, I think I'd be stressed because I think teaching is one of the most incredibly hard things to do.
Yeah.
And the idea of doing it stresses me out. So I can't imagine what it's like doing it for a profession. Anyway, they sit there and they often almost shake with anxiety, telling me the sorts of things that are stressing them out. Colleagues, deadlines, Ofsted, parents, kids that they can't manage in a class. I mean, how do you manage a classroom of 30 when there's 3 or 4 of them with a diagnosis of ADHD, when they've got specific arrangements in place? How do you manage all that and not get stressed? It would stress any of us out. So that's what they're telling me. So lots of systemic stuff, and you want to help. You want to help as much as you can, and there needs to be a more global, holistic assessment. But the thing you can do then and there to kind of move on, get it off your plate for the day, is to write a note. Yeah, which is what we're doing. And
often that is the right thing to do.
Yeah,
people need that time, and that's absolutely right. But then it's how do we then get people back into work?
Yeah, because the pressures aren't going to go. Even if they're 2 weeks, they're going to go back into that that bear pit, aren't they?
Yeah.
With all the pressure that. So it's about trying to. Yes, we can help manage that person's stress and anxiety. What's happened on the other side to reduce the pressure of the role?
Yeah.
Are the government doing enough to sort of mitigate that? I don't know.
Well, I think we need to rethink it completely, because the pressures on staff certainly I'm talking about education, the pressures on staff in education are becoming so burdensome that I think these numbers are going to increase continually.
Yep.
Let's move it on a little bit, Tom, to talk a bit about potential. What can we do together between health and education that might, we're not the government, we aren't in control of policy, but what could we do without necessarily having to use that lever? Now, I've got something I'd like to share. I think you've got something that you tried it in your surgery. So, and then we'll maybe just see if there's anything else that we can think about. So the thing that I'd like to just share with you is something that we did in my school where I was head for 19 years. One of my friends was a GP in the area. So we set up a little partnership between the school and the GP practice. And all year 6 pupils in their science lessons did posters and artwork and public information booklets around health. Healthy eating, healthy diet, against smoking, all these kind of things, So it was part of their curriculum. And then they would take all the materials down in groups of 6, and they all had a session across a term or a year. And they went to the practice, and they would engage with the patients in the waiting room, engage with the nurses and the doctors, use their oracy skills to talk about what they'd learned, and delivering a kind of public health message. And then that led on then to a second project, which was the same children then walking with patients in the local area, just a sort of health walk. And the older patients would talk to them about the history of the area, and it was that kind of intergenerational thing. So there's something, for example, I don't know whether you think that's something that could be replicated.
That is such a fantastic idea, Jeremy. But it's come from you and your friend is Kevin, isn't it?
Kevin, yeah.
So you two have got together and gone, wouldn't this be great? So it takes individuals like that with a like mind who spot an opportunity and then deliver it with lots of energy. It sounds brilliant. I'd love to replicate that down in Hertfordshire if we possibly could. I'm not quite sure how I'll get off the ground, but I think that's a great idea. Yeah. It sort of ticks so many boxes, isn't it?
And then, Tom, you were telling me about something that you tried. I know finances why you haven't been able to sustain it, but go on, tell us about, because I thought it was brilliant about staff.
Yes, we had something called the Primary Partnership, the PPP, the 3 Ps, P cubed, and I think it was on the back of a conversation we had probably about 10 years ago. And I've always been quite inspired by how community focused you've been over the course of your career, how you've gone beyond the walls of the school and sort of gone out into the community. So I was quite inspired by that. And about 10 yards from our practice is Primary School, stone's throw literally away. And I'd never been in there. So on the back of our conversation, I literally walked around at lunchtime, met the head teacher and said, I'm a GP next door. She was like, well, I know your name, but I've never seen you. And I was like, well, yeah, I'm trying to sort of sort that situation out. Here I am. What can we do? And we had a couple of things we were going to do together. One was She was saying lots of mums, particularly single mums, were presenting to the school gates very stressed and very anxious, but didn't want to reach out to a medical professional. For some reason, some GPs aren't particularly accessible or aren't perceived as accessible. And certain people with anxiety particularly don't want to go and talk to someone like that. So they want to talk to a dinner lady at the school gate or a teacher. So often they'd present at the school gate and say, I'm really stressed. And there was no real mechanism for us to get access. So what we did, we had 3 appointments in my surgery each week where the school would book a parent in. So they'd have to get consent from the parent and say, listen, I think you're stressed. I'd like you to talk to a GP. Can I book in with Dr. Gillham? And they did. So it was a way that someone else could intervene to book in, and then I'd contact the patient and have a really good chat, get them on treatment or get them the support they needed. And that was purely because the school and the practice worked together. Very simple, based on a 10-minute conversation with a head. And then a couple of other things we did. We had, certain complex children with lots of high-level needs that weren't getting the support they needed. Again, they'd be booked in with a GP for a prolonged period, for a sort of prolonged appointment. So that simple thing worked brilliantly, but it wasn't sustained.
So why wasn't it sustained? Money?
Probably money. And I won't bore you with practice finances,
politics,
and the way the NHS is financed.
Okay. So I love the point you made there around early intervention. So tell me what you think about this. And I put it out there to the folk watching. Bridget Phillipson, Labour government. I criticised them before. I'm going to say this is great. Policy of early start family centres. Pledged to open 1,000, I think, by 2029. There are a number already up and running. I think that's brilliant.
Yeah.
That is exactly the right policy. Now, what I think we need to go further with those family hubs, and we need to make sure that there is integration with health. And you're going to tell me about neighbourhood health centres in a moment, but I am going to put the case that Best Start family hubs should have health as part of their governance structures to ensure that we can look at early intervention for both children, but also for adults.
Yeah.
What do you think?
I think it's a great idea. I think it's a really good idea. I don't know enough about family centres to comment with any level of expertise, but the concept's absolutely bang on. It does align with the concept of neighbourhood health centres, which should I talk about that briefly?
Yeah, go on.
So big drive at the moment in the NHS. It's all about neighbourhood health. It's all about taking activity out of the acute trust, expensive acute hospital. Let's move it into neighbourhoods, care close to home, all these ideas. And this, to me, fits perfectly with the sort of family's agenda. So what we're trying to do is to design healthcare in the community where we work alongside community services, local government, the voluntary sector. And I've sat there in meetings. We've had brainstorming sessions across sectors. And that has been an innovation or progression in the last 5 years. We are working closely with local government and with voluntary sector, hugely. So I think we have to bring in schools and families.
So who's, in those conversations then, who is representing education?
We haven't got...
Bingo!
Well, yeah, okay. So I guess, we haven't got education there. And I'll tell you why. It's because we're focusing on a different cohort. We're focusing on frail elderly. We're trying to get patients out, the inappropriate admissions to emergency services. We're trying to keep them out of hospital by proactive care. So generally over 85s with multiple illnesses. Let's focus on them. They're an expense to the system. They need wraparound care. And we're not really prioritising children in that model, but it needs to come in. Okay, so we did have that meeting, and actually that was called a 3P too, a 3P meeting with lots of professionals, and there was education in the room. There were schools and families, and one of the top paediatric nurses from the local trust, and they kept saying to us, "You're going to go off on one about frailty. It's all about adults and mental health. Don't forget the children." And we're still designing it without children fully in mind. So we have to dovetail that in, to presumably Bridget Phillipson and Wes Streeting can have a chat, can't they? They can bring that in.
So basically it goes back to what I said in my introduction, that really we're not doing enough, are we, for the next generation? We have to and that's partly because of resources, because of pressures, understandably. So it's not this, I'm not saying that the will's not there, but basically we're putting most of our eggs into the basket of dealing with the elderly, dementia, because they have to come first. And unfortunately, children,
they're an expense to the system. We're trying to free up resource. That would be the wonderful thing, to free up the resource, then sort of put into, better proactive care for kids. But it's at the moment, in the conversations I'm having, it's not the priority. But we need to make sure, as my colleague said, don't forget them, because we're at danger of doing so.
Okay. All right. So where are we up to then? We need to be further upstream, don't we?
Yeah.
Which you're trying to do with neighbourhood health centres. Maybe we're going to be trying to do that with early start family centres, prioritising that, I would say, public information. One of my dreams really is that we're able to deliver to parents, particularly that age group, sort of when the child is 4 or 5, some really clear information about what all these conditions are, ADHD, autism, and so on, so that parents really understand the expectations of what schools and wider services can do, and that there's loads we can do in the intervening period without having to go to diagnosis necessarily so quickly.
Yeah.
And working with parents to give them all the tools necessary to be able to support them before we've rushed to this, got to have a diagnosis for whatever reason. We know it's been linked to money over the previous sort of 12 years, and we dealt with that in the last one. Anyway.
Yeah.
Any other thoughts about way forward?
So we talked about over-medicalisation, didn't we? Are we medicalising something which is behavioural or societal? And I think generally, whether it's children or whoever, we are living in an over-medicalised society.
Yeah.
So let's demedicalise it. Let's stop giving people these labels. Let's get them access to any support they need without having to have a label. But let's try and empower parents to make good decisions, to support them with good parenting decisions, basic stuff at home they can do to help their kids thrive and be healthy. And I think sometimes, because parents don't feel supported, or because there's precedent with other kids with diagnoses, the knee jerk is to go and get help, get a diagnosis. So I think public health, I think education from primary care, posters, websites, apps, all these things can help massively to try and get ahead of it and actually just take the medicalisation out of the whole area.
Do you know what? Little challenge to you.
Yeah.
Another thing. Why don't you try and spend a day in a primary school?
I'd love to. I'm not sure I'd survive, but
yeah, I would just sit in on a few lessons.
Yeah.
Sit in, talk to the staff in the staff room. I wonder what difference that would make. I think you'd pick up an awful lot.
Well, I will come and spend a day in your school.
Yeah.
If whichever school you now work. Well, you work at one of your schools.
Yeah.
If you'll come and spend a day at pediatric surgery.
Okay. Right. Well, it's been a thoroughly interesting discussion, Tom. Thank you for that. I think in conclusion, number one, we've got to get things further upstream and get them early. Secondly, we have to be looking at more formal, structural partnerships between health and education. And I would suggest governance arrangements need to reflect both of those areas. If we're going to deal with this huge, huge rise, both in child mental health, but also adult mental health. Any last reflection from yourself, Dr. Tom?
Mr. Barnes. One key takeaway for me really is that at the moment, we've not got you guys' education at the table.
Yeah.
We're sitting there with local government, charities, voluntary sector, community trust, GP. Where is education at that table? We're prioritising the elderly. We need to make sure kids aren't forgotten about. So let's get them in that conversation. Let's get them into neighbourhood health.
One thing we'd like, I think, for all of you who subscribe to Bald Headteacher, and those of you watching or listening to this, I think this is a really good one for getting you involved. We'd love to hear from you. What are your experiences of partnership with health, or if you are in health, what your experience of part of education? I think you'd quite like that as well, wouldn't you?
Yeah, I'd love in your comment section if teachers, education leaders I'd love to hear about your experience of general practice.
Mm-hmm.
How is your GP? How could they have improved things for you? Were they supportive? Did you get a fit note too easily? Did you expect a fit note when you got one? That sort of thing. I'd love to hear from you. Just on that, really.
Yeah.
Yep.
And just one thing for the listeners, Tom has been desperately trying to get himself into our family now for many years. Okay, you've been harassing me to get on this podcast.
Thank you.
You are now part of the family, Tom. You're made.
Thank you for the opportunity, Jeremy. I'm honoured deeply.
Okay. Thank you for watching. Thank you for listening. Look forward to the next episode. See you again. baldheadteacher.com. Adios.